Welcome, everyone. Thank you for joining us for today's webinar. My name is Thomas LaVeist. I'm Dean and Weatherhead Presidential Chair in Health Equity at the Tulane University School of Public Health and Tropical Medicine. We acknowledge that the land on which New Orleans is cited as Balbalcha, a Choctaw word meaning a place of other languages, and we honor generations past and present of the several tribes who live in this region. Today, we are presenting many voices, one goal, next steps advancing health equity, the inaugural webinar of Partners for Advancing Health Equity, led by the Tulane Institute for Innovations in Health Equity at the Tulane School of Public Health and Tropical Medicine, and supported by a grant from the Robert Wood Johnson Foundation. P4HE is a national learning collaborative of scholars, funders, government, community members, and private sector representatives working together to understand the latest issues related to attaining health equity. P4HE seeks to foster synergy across sectors and align efforts to create priorities for research to address obstacles to health equity. Today's event marks the start of a series of participant-driven initiatives with the goal of bringing health equity stakeholders of all sectors to the table to build an actionable and sustainable solutions. So what's different about this approach? We want to break down silos and bring into conversation people from academia, philanthropy, government, the private sector, and community leaders to build a national dialogue to advance the way that we conduct research to bring about health equity. Our program today includes a section designed to further explain our approach to achieving health equity, led by our Associate Director, Andrew Anderson. That will be followed by a panel of speakers from across a spectrum of sectors shaping health equity. The panel will feature Sharrelle Barber, Sinsi, Hernandez-Cancio, Kara James, and Al Richmond, who will offer their perspectives on how they think about and address health equity. We'd love for you to engage in this conversation. So please share your thoughts on Twitter by using our hashtag, Partners for Health Equity. That's partners, the number 4, the letters H and E. Now please welcome Andrew Anderson, Associate Director of Partners for Advancing Health Equity and Assistant Professor in the Tulane University School of Public Health and Tropical Medicine.
Thank you, everyone. Feel free to follow along in the chat. We'll be providing relevant information throughout the webinar, including a survey at the end, so we'd appreciate it if you fill that out. So we want to first start by painting a picture of where we are and where we hope to go. The call to address health inequities isn't new. This learning collaborative is joining a long tradition of people who aren't satisfied with the status quo. We know health inequities are morally wrong because they represent injustice. They also exist in stark contradiction to our ethical principles. The failure to live up to these principles has been brought to light through activism and documented through lived experiences and scholarship for many decades. Health equity research has been chronically underfunded and has rarely received the attention it deserves. But we're currently living through a time where the attention to health inequity has arguably never been greater. And the solutions lay in targeted investments, policies, and programs that go well beyond public health and healthcare. We as people who are dedicated to this work have come together to advance these solutions, and we know that it will require approaches that recognize the interconnectedness of social issues. The pandemic has once again surfaced the need for access to basic resources for people to live with dignity and thrive. In response to the pandemic, emergency measures were provided, but when the emergency relief ends, millions of people, including millions of children, may lose these needed resources. Funding for policing is increasing in cities across the US, yet homelessness and food insecurity is on the rise. Wealth inequality is increasing, as are deaths of despair. We know necessities like access to food and housing and safe places to live directly impact health, but there are many other factors, including non-health policies and programs that can indirectly impact health, and some of those are currently under threat. Over the past decade, the Supreme Court, through several decisions, has weakened the Voting Rights Act, which is responsible for ensuring the right to vote, especially for Black Americans. And we should spend some time really sitting with this reality because it's so fundamental to the success of health equity work and democracy generally. Gerrymandering is rampant and unchecked. Now the Supreme Court will debate the need for affirmative action, and many think the practice will end. Reproductive rights are on the chopping block. Our system of immigration and asylum unfairly privileges some groups over others. These issues may seem distant to some, but are in fact tied to many of the solutions that we need for addressing health inequities. And it's more than just politics. We too often ignore our shared humanity and fate with people throughout the world. We've seen corporations, and many of which have questionable business models and practices, stepping in laudably but inadequately to fill large gaps in our public safety net. Yet we see these same companies engaging in exploitative work practices, domestically and abroad. All the while overshadowing these issues is an imminent climate catastrophe that will undoubtedly displace the same communities that are already victims of a long history of unremedied injustice. For instance, the Isle de Jean Charles community, just outside of New Orleans, where we are presenting to you from today, which is primarily a Native American community who escaped the 1830s Indian Removal Act and the Trail of Tears, is now facing resettlement because of the impacts of climate change. For over a century, the Native Americans on the island fished, hunted, trapped, and farmed among the banana and pecan trees that was once abundant on this island. But since 1955, more than 90% of the island's original landmass has washed away, and now they're the first to receive federal tax dollars to relocate. Many don't want to leave, and given the history, some have expressed distrust in the government. These circumstances are co-determinants of existing inequities that shape the social environment. Fortunately, it's not a mystery how we got to where we are or why. We have the power to make real change possible. We have mountains of empirical evidence documenting health disparities over decades. We also have critical theories that reveal and challenge power structures that perpetuate these inequities. But we have a long way to go. Our system of laws and policies from the past and today shape the existing distribution of power and resources and create systems and social norms that lead to these differences in outcomes. Because these root causes have rarely been addressed, we've seen relatively little change over time. So we need a new approach that actually serves communities in leading the charge for their own liberation. We believe this learning collaborative, Partners for Advancing Health Equity, will foster the co-creation and spread of knowledge by bringing together people and organizations with a shared commitment to achieving health equity. We will continue to bring attention to health disparities, but we aim for this learning collaborative to sharpen our research tools, harmonize our voices, and challenge the status quo to shine light on practices and outcomes that we think are indefensible, irrational, and inconsistent with the moral principles we believe in. This learning collaborative will be led and shaped by its members. And we aim to disrupt traditional research approaches to make it more effective and useful for communities seeking change. Research is slow. We recognize people don't have time to wait and are frustrated with the rate of progress, but we need to come together to create new knowledge and consensus for advocacy, policymaking, and ultimately social change. For instance, how do we make grant funding more accessible, transparent, and aligned with the needs of communities and society? How do the incentives at institutions hinder or facilitate health equity research? How do we meaningfully support communities in leading this work? The answers to these questions will require that we have honest conversations about what it's going to take to achieve health equity. And to that end, and before we move on to our panel, I leave you with this quote from Dr. Martin Luther King. Our goal is to create a beloved community, and this will require a qualitative change in our soul, as well as a quantitative change in our lives. I want to thank all of you for joining us on this journey to create this learning collaborative. Now I will turn it back over to Dr. Thomas LaVeist, who will be moderating today's panel.
Thank you, Andrew. Sharrelle Barber is director of the Ubuntu Center for Racism, Global Movements, and Population Health Equity at the Dornsife School of Public Health at Drexel University. Sinsi Hernandez-Cancio, Vice President for Health Justice at the National Partnership for Women and Families. Cara James is President and CEO at Grantmakers in Health. And Al Richmond is Executive Director at the Community Campus Partnerships for Health. Welcome all to this conversation. So I'd love to make this a free-flowing discussion, so please feel free to chime in with your comments and insights. Research and advocacy to promote equity for most of its history has focused on proving what people already know through their lived experience, that there is discrimination, that services aren't available or affordable, that communities are being polluted, or schools don't have resources, to name some, just to name a few. What do you think research in the past has failed? Where do you think research in the past has failed?
Well, so first of all, thank you, Tom and Tulane, for hosting this conversation. I'm excited to be joined by such illustrious panelists for this conversation. And I think, one of the places, there's been a lot of work on health equity and health inequities over decades, and lots of people have been responsible for this work, including yourself. And I think that I don't want to say that the work has failed so much as I think one of the places that we have maybe relied a little too much on is the moral suasion argument, that if we showed these inequities that we would get the change that we need. And I think that that has clearly not happened. So I think there maybe the premise of what it takes to our theory of change is one of the things that we may need to focus on. And I would say that where we need to do more work is again, thinking about a paper that you had in 2009, looking at that economic cost, tying this to the money, to the things and the outcomes that the people with the money care about. And how we make that business case for health equity are some of the places where I think we need to focus more of our attention and look less maybe for that moral suasion argument.
Yeah, I would.
Please do.
I would 100% agree with Kara's assessment. It's rare when I don't agree with Kara, just to be honest. Thank you so much, Dr. LaVeist, for inviting me to this panel. And to be in community with so many excellent leaders in this field. I think the other place that I don't want to say it's a failure, but I think it's maybe surely an area of growth is that we have gone from thinking about inequities and disparities from Black-white to Black, white, and other. And I think that a lot of the work that people are really leaning into now more is disaggregating it out, right? And getting rid of that horrible other category because it's in addition to it being dehumanizing, it's simply not helpful from an analytical perspective, right? I think that one of the biggest challenges, apart from the model of healthcare having to be a wealth generating activity as opposed to a health generating activity, is the fact that we just don't have solid data that will not only allow us to target resources and interventions in ways that are most needed, but also that promote the kind of accountability that we really need to hold the political and economic systems accountable. We have to measure what we treasure, and we don't measure right. Another way of thinking about this is you don't count unless you're counted. And that's something that I think we all need to lean into more. And we have an opportunity now with the way that COVID has elevated how particular communities are doing to build on that momentum, hopefully, so that we can get to better data systems that are more transparent and equitable.
Yeah, thank you for that. And Sinsi, please just call me Thomas. Al, you look like you wanted to weigh in?
Yeah, I think there's some consensus among all of us around some of the shortcomings of research. And actually, I would just weigh in by saying I think there's been an over-reliance on research, quite frankly. And what comes to mind is, this whole idea that knowledge production in and of itself actually validates inequities, when it's really, to me, the lived experiences. People have been saying this for years. How much more research do we really need? And how many more dollars do we need to spend in the area of research at the federal, local level to really just, bring home the case that there are inequities, they are real, and they are systemic in nature. And so I think that's some of my concerns. There's a project out of Chicago. I'm going to paraphrase the title is Why Am I Always Being Researched? Where African Americans in particular in Chicago are saying, why are you always researching me? It's like, what good does this research do? We know that there are problems. And so I think it's the shortcoming of over-reliance on research. Sharrelle, what do you think? We've talked a lot about these issues. I would love to know what you're thinking there.
Yeah, no, I think that's actually right on. And I think that it's also been a lot of research on the problems and not on the solutions.
Mm-hmm.
And so we have focused, and it was necessary, right, to, I guess, document the inequities. But I think that in so doing, one, we have almost over-relied on looking at the pain and not appreciating the power of communities that have been harmed by these systems and structures of oppression, and also not recognize the ways in which communities who have been most harmed have come up with solutions, pretty powerful ones, in the face of this great harm. And the pandemic is a prime example of that. You saw at the very onset of the pandemic when local, state, and national government failed communities, it was communities who came to the aid, to help with food. And to think here in Philadelphia, we had the Black Doctors COVID Consortium who was testing and providing vaccinations, and off of little funding, but they saw a need. They developed a solution, they executed that solution. And it is a story of how you can kind of look at this and look at the inequities, but then act, not just sit on the data, sit on the quote unquote knowledge production. So I do agree, Al, that this idea of communities are tired of being researched, they're ready to get to the solutions. And I think, in fact, those who have been most harmed by these systems and structures are primed to be some of those solution generators.
And Thomas,
Sorry, this is good. Go ahead, Al.
Yeah, I was just going to say, I think that, as I listen to Sharrelle, it's like there's almost a paternalistic attitude around research, right? It's like, we know best and we're going to tell you what's best. And our research is going to document it and we're going to tell you the way forward. And so for me, I've just been thinking about how much more research do we need around, I remember some of these projects that have gotten funded around increasing physical activity among African-American women without even looking at what are some of the challenges and barriers that women may face every day. They may not be exercising simply because they're working from 8 a.m. to 11 p.m. at night. And so when are they going to exercise? Yeah, again, it's this paternalistic attitude around research, and it's not real until the research says that it's real.
And I think what I want to maybe tease out a little of a dichotomy that I think we're talking about. There's kind of the how we do the research, and there's the actual research. And I think that one of the things so for 8 years, I sat at the director of the Office of Minority Health at the Centers for Medicare and Medicaid Services. The research is critical because we can't make policy on anecdote. And even though we know there are problems, we still have, and I would say health equity research in particular has a higher bar for action, in part because people use that as a way to not do things. So we need the evidence, and as much as it's frustrating in terms of documenting, we still need that National Healthcare Disparities Report to show that 20 years later, 95% of the disparities have largely remained unchanged, because without that evidence, we can't move forward. But I think what Sharrelle and Al, you guys are talking about really is the how we do the research, what we're focusing on, and what's needed to move it, because the evidence alone doesn't make for action. But I think there's still that kind of conversation of, there are some who still are not believing that they're disparities, or believe that they are the result of whatever over there, and that's not what we need. But to your point as well, of thinking about this from an asset-driven perspective rather than a deficit model is really important. But we need the research. We need the research focusing on the solutions so we can see how to expand those to move forward.
Yeah, I want to add to that, because it's not a question. I mean, I believe we need the research on solutions, like people have said. We need to hold those that fund research in general, especially health systems research and just medical research straight up, more accountable for actually focusing on equity, right? There should, in my opinion, there should be no program out of the federal government or out of any university that is allowed to report without disaggregated data, right? Because we don't care just about the average outcomes, the distribution of outcomes matters. And as long as we don't hone in on that, we're not going to make progress. But the other thing is that, you know, I think that it's true that for many things that are completely inappropriate, we're tired of being researched. But there's also things that we are not researching. Like I, as a Puerto Rican woman who almost died giving birth, am really frustrated that the last time maternal health outcomes were researched in any particular, way, knowing that these inequities exist, was 15 years ago, right? Lumping us in with the rest of Latinas doesn't work, because our experiences as a community, which we know exists when you look at Boston or when you look at New York City or specific areas, gets completely diluted out when you lump us into everyone else. And let's not even talk about the huge differences in the API communities and the fact that, small sample size constantly gets in the way when we're trying to look at indigenous communities, right? So I'm a believer of research. I do believe that research is not the only thing, though. You need to have, as an advocate, because more than anything, I'm not a researcher, I'm an advocate. We need to have the 1-2 punch of the facts and the stories, right? The egghead stuff, the wonky stuff, and the heartstrings, what it means to real people stuff. And that's how we win. And then the last thing I'll say, I'm getting a little bit animated here because these things animate me, is that, we already know that there's been a lot of work in the last several years trying to get more diverse people in research, right? In medical research, which has been a challenge for very good reasons, right? We like to talk about evidence-based medicine, but you know what? Medicine, first of all, is 50% art and not science, right? And that's what the National Academy of Medicine says. I'm not making that up. And number two, it was generated on whose bodies, on whose experiences, not on mine. And we take it on faith that whatever works for a white man is going to work the same way for everyone else. Sometimes that's true, sometimes it's not, but we don't know. We are mostly guessing, and we need to do better than that. We need to be transparent about that.
So let me push you a little bit on that. So doesn't that create a mixed message? On the one hand, we're saying there's enough research, we don't need more research. There's a group in Chicago saying they don't want to be researched anymore. On the other hand, you're pointing out that much of what we do in the health sciences is the result of research done on white males that we're extrapolating to everyone else. So how do we resolve that conundrum?
So my answer is that it depends, again, on how the research is constructed and who and what you're researching. I don't think we need to research anymore as much on identifying problems, because we know they are, other than what Carol was saying, where we need to continue to document, to build the evidence base. I'm a lawyer by training, so I do think about evidence, to building the evidence base for continued action. And not that a problem exists, but the why of the problem is what we really need. We need people to understand that it's not because we make crappy choices. I'm sorry, I should not speak with that kind of language, that we make bad choices, but it's about like what is out there, what are the choices to be made, and research like what happens with weathering and the lengths of your telomeres and all of that is really compelling. But at the same time, even though we know, for example, that asthma medication, albuterol does not work very well for Black and Puerto Rican people, I want to know where the research is of developing drugs that are going to be better for Black and Puerto Rican people, right? Because we have disparities in death rates, and there's no good reason other than that we haven't done a good job in creating solutions and for people in this country to be dying of asthma, right? So though that's, I think, it's a lot more nuanced than don't research me or I'm tired of the research. It's like who, what, and for what purpose. And, are we looking for problems, or are we just that we know already exist and wasting money and resources that way? Or are we looking for solutions and what solutions actually work with whom?
So Sharrelle or Al, would you like to respond to that?
Yeah,
Well,
sure. How does that play out in Philadelphia? I mean,
well, one of the things I actually really appreciated your point about the kind of how these inequities came to be, because I do think there's a lack of work that has really fully engaged the complexity of these issues. So, you all talked about this idea that, health is produced because of these intersecting inequities, these intersecting systems of oppression. And we have not done, I think, the extensive work to think about how this, historically this plays out, how these, structures and institutions kind of connect to one another and reproduce and create the inequities that we do see. That's actually something that I don't think we've done enough of. Mm-hmm. And in fact, if we can understand how we got here, it may produce evidence that it's helpful for thinking about how we undo these things. So we've built this system, this nation, this world that we currently live in, that has produced staggering inequities on so many different health outcomes. And so how do we rebuild it? But we don't know how to rebuild it unless we understand how we got here. And I think this pandemic has been an inflection point that really showed that interconnectedness. For example, we could have done all the testing, et cetera, early on in the pandemic. But if you didn't think about workers, if you didn't think essential workers, if you didn't, think about what that meant for transportation, especially when folks were staying home, if we didn't think about, all these policies that were coming, they were disparate policies, but that were coming into focus during a public health crisis, and so to focus only on one aspect of the problem actually did not solve or didn't, mitigate inequities. And so that's where I think a good, nice sweet spot is, to understand the complexity and really deal seriously with the complexity of these issues.
Mm-hmm. So Karen, I wanted to follow up on something you said earlier that I thought was really interesting. You kind of alluded to the work that I had done some years ago on the economic burden of health inequities. I should say this is a little plug that we are coming out with an updated report this year. So we'll have new numbers later this year.
You get a check for the plug, right?
Yeah, I'll send you. I'll send you a percentage of my zero that I get for that study. But you made a comment, you said that we need a new theory of change. And I thought that really resonated with me because, it was early 1960s when the Surgeon General indicated that smoking was a carcinogen. Now here we are nearly 60 years later and people are still smoking. So one thing that has been abundantly clear is that simply informing people of things is not going to lead to change. And you said that we need a new theory of change. Say more about that. What do you think would be the components of this new theory of change if just informing people is not enough?
Yeah, I think it's a great question. So I think that the theory of change that I think we have had for many years in health equity is that, again, if we showed the inequities, people would work to address them. I think that is false. We are in a space now where more people clearly are committed to addressing these issues, but we do have a lot of folks who are not and are really just what I would say biding their time before we move on to the next bright, shiny object and go back to the way things were. So I think that part of what we need in this theory of change is thinking about, and I like to say that for all of the things that Sharrelle just said, we need to be looking at the intersection of all of these issues. For too long, we have thought about these in silos. Mm-hmm. Healthcare is in this silo, education is in this silo, income is in that silo. They clearly have been linked all along, which we all knew, but I will say some others have sort of recently woken up to that, and that we need to have more of that intersectionality in our approach. And by that, I mean the way that we're going to address the disparities. No one sector, academia, business, education, healthcare, is going to fix these. So we all have to work together and strengthen the partnerships, many of which are already happening in community, but have these partnerships happen at a higher level, which means when we think about what moves people, I think about a project that was looking at readmissions and a collaboration between the health system and the Community Development Corporation up in Pennsylvania. And they showed that they reduced hospital readmissions, ED visits for those who had frequent visits. But that wasn't the outcome that the Community Development Corporation needed to be able to show success. So how do we get more bilingual and multilingual to talk to business, to talk to education, to show outcomes in the ways that help them continue investments or strengthen investments to move forward, given this intersection? I think the other piece, and going to the intersectionality, we do have data gaps. We do not have great data for a lot of those root causes that we think about. We don't have great data on acculturation. We don't have great data linking immigration and other pieces. And we have, as Sharrelle mentioned, we need to make some of those linkages clear between how do you get from, and the example I will use, Medicaid policy and payment to inequities in access and quality and disparities that we see. Because, it's very clear, Medicaid pays a doctor less than Medicare, who pays doctors less than commercial for the same thing. I think we all can agree that is an inequity, a structural inequity that is in our system. And because of the other intersections that we have with income, disproportionately affects people of color. So how do we get better data and linkages to make that conversation more relevant and present to people are some of the things that I think we need. And I think, again, Sinsi said she shouldn't say crap, I'm going to use the reference, Biggie, it's all about the Benjamins, baby. You've got to get to the money, because that's what people are focusing on and caring about for those who are holding the purse strings for the big programs. And we need to be thinking about how do we build equity into our policy programs for sustainability, so we don't need a special initiative or a special grant or some charismatic leader at the top who's driving it.
So several of you have talked about the pandemic, and obviously the pandemic has unearthed, well, maybe to many of us, maybe it didn't unearth much of anything, but for a lot of people, it unearthed things that we have been talking about for many, many years. And as a result, health equity is much more prominent and getting much more attention, just because of the realities of where we are. How do we make the best use of this moment? How do we ensure that we take this opportunity where there is a focus on health equity among people, unlike those of us in this conversation who've been doing this basically our entire adult lives? People who have not been focused are now paying attention. Now that we've got their attention, what do we want to say?
So I think this connects very much with the point about what is our theory of change, right? Because this is like the example of it's not just a question, this is not about moral outrage. This is not, that doesn't move people. It's about their self-interest when it comes to like individuals. And it's also very much about creating, the money narrative, right? And so people really finally saw what it means when the people that provide their services aren't available, right? What it means when you don't have, when people in your community, people who go to school with your kids don't have access to care, don't have access to vaccines, where there's no infrastructure that needed to be able to address these challenges. What it means to not be able to go to the hospital, not because you can't afford it, but because there's no space, right? So I think we have an opportunity to connect where people are feeling a bit raw about what's actually needed for the common good, for the economy to move forward. I think that there's limitations to that, because as long as we are only talking about like it's your own enlightened self-interest we're still going to miss a lot of people. And at the end of the day, these are all really political decisions. And I think that, you know, for that, like my brother from another mother, Daniel Dawes's work on the political determinants of health are something that is really important for us to think about, that it is also about, there's an opportunity now for people who are a bit outraged to think about, okay, well, how do I make that more than just pearl clutching and being upset, and channel that into something more productive.
Okay. Sharrelle, did you have something?
I'm still thinking. I want to respond to that, but give me a second. I think Al might have something, or at least he's on. He's not.
Okay, Al is back. So, yeah, sorry, Al, we lost your signal. We really couldn't pick up.
No problem. I just wanted to just pick up just with Kara's point about intersectionality. And I was saying that, you know, my background and training is in social work. And I would actually envision systems where people are working across disciplines. And, you know, if there's anything that, you know, into tying it back to your, you know, to your immediate question or recent question, is to get people to work together across these disciplines. And what that would look like is, and I think it means we have to retrain ourselves such that we're not looking at things in the past. A great session I went to was by Kimberly Crenshaw, when she talked about the intersectionality of disciplines. And I said it, critical race theory. And it really brought home the point that every discipline has contributed to inequities in this country. And as long as we see that in kind of siloed approaches, then we'll just think of it just like that. Like this is an issue for social work or medicine or public health. And I'm hoping that going forward, that we'll see less of that, where we'll see people as whole beings made up of different parts of them. And as a result of that, we will begin to develop policies and practices that really acknowledge them as just being just that, and that what their needs are, our collective needs are, to be seen in a way that respects and honors who we are in our totality.
Yeah. The way I like to talk about that is that, you know, any really important problem is too complex for any one discipline.
Right.
And I think that the COVID response of the previous administration demonstrated that with their Operation Warp Speed, which is an outrageously unfortunate name for an effort to create a vaccine, focusing on the speed at which it's being moved rather than the care it's being taken to create a quality vaccine. But the focus there was on creating the vaccine. And of course, vaccines will do nothing for a pandemic. It's the vaccination that matters. And you need much more than virologists to get vaccines. You need virologists to get a vaccine, but you need much more to get a vaccination. And so the focus on the virology and ignoring the communication science, the sociology, the anthropology, the psychology, all of which has turned out to be perhaps even more important, is why we didn't really get the progress that we were hoping to get with the creation of the new vaccine. So you're right, the important problems are too important for any one discipline.
I think you bring up a really important point that is going to be with us going forward is narrative, information, misinformation, and distrust. Those are here to stay for the foreseeable future. And we need to be taking those into account. And I think what health equity needs in terms of this moment and making sure we need more time, because people are thinking about this as a 30, 60, 90 day, or, you know, here we are 2 years later, haven't we solved the equity issues and we're done with it, we can move on. That is not the case, because these things are things that took decades and centuries to happen, and they're not going to be teared down overnight. So we need to, this is a window of opportunity that we have, and we need to prop that window open so that we can actually get some of the work that's needed done. And I think narrative change and how we talk about the inequities, the causes of those, is important, because we've, I'm not going to get into the right or wrong of this, we've kind of rammed health equity down and racial equity down people's throats for the last couple of years, which means that people who are sitting on the sides angry, feeling like they're being, it's costing me to do this, we have to bring more people into the conversation and kind of use that community-based participatory model of meeting people where they are so they can enter that equity continuum and move forward. Because we are really polarized as a country. Everything is political. But we need to have that narrative change, that we own the narrative, because that's another thing, that there are a lot of people who are coming into this space creating narrative and getting credit or, props for narratives and things that they may not be as expert in. And we need to own that narrative and prop that window open so that we can continue the work that needs to be done, because this is going to take us a generation, decade.
I actually really appreciate that idea of time. And it was, in fact, what I was thinking about in response to, these inequities have, been created over centuries. I think time is important, but it's also, what does it mean to build collective power in this moment as well? So we don't move systems and structures or even policies without creating and leveraging power. And so what does it mean in this moment when we have literally we are in an existential crisis of humanity, climate crisis, health crises, all of these things. And so if we, tiptoe around the tulips, or if we, don't, really think boldly and audaciously in this moment, what other moment will we have when so much of the veil has been lifted, right? And so in this moment, I think, it's important that we think about power. And I would say we think about politics, but not in the normal partisan, Republican, Democrat, left, right, but like that the distribution of resources is fundamentally wrapped up in issues of power and issues of who gets to control the things that, should be, of common good, right? And so these are and I think that as much as this moment calls for some of the kind of technical kinds of questions around, what we do and what solutions, like, what is our imagination for this moment? Like literally what we've experienced and are still experiencing requires really kind of a bold and a radical imagination about what could be. And if we lean into that imagination in this moment, what could we create collectively together, right? And so I think there's a power in this propped open moment. But if we and I feel like we need to push the door open because, our ancestors didn't, die, give blood, sweat, and tears for us to come to a moment like this where we have so many resources, right? And we just, we fail to be bold in how we, we act in this moment. The last thing I'll say, I was on another call earlier today, and, again, in this, space of being aspirational, what does it mean to be a good ancestor? Because what we're doing today is actually it may change some of the things, but it's actually more about future generations. So what is it in this moment in 2022, when we've endured a pandemic, when we've seen so many instances of state-sanctioned violence, when climate change is, really threatening our future, what does it mean to be good ancestors to generations down the road? And I think that's where we have to be in this moment if we're going to really push the door open.
So you talked about power, and Sharrelle, I asked you to keep your mic, unmute your mic and keep it unmuted because I want to hear more from you. So you talk about power, and so I'm making an assumption based on what you said, and at least my thinking of it is that by power you're talking about who controls resources, right? Who gets to determine who gets what? Is that what you're referring to?
That is one aspect of power, right? Yeah.
So say more about that.
So there's one that's the aspect, like who controls, who gets to make decisions, et cetera. But there's also this collective power that we've seen throughout history of movements, really, of the folks who decide that in a moment in history that we're not going to kind of accept the status quo. And so the power that I think we can leverage in this moment is the collective power of movements. It's some of the work that we're, doing within the context of the Ubuntu Center, really leaning into what movements teach us about how change actually happens, actual transformational change, right? We know that the civil rights movement led to, fundamental changes that shifted how this country operates, right? We know that there have been movements around the globe who have done the same thing. Have we gotten everything? Absolutely not. But we are coming into about a decade of movement building through the movement for Black Lives and other movements that has pushed us to think about these systematic, these structural, these fundamental causes of health in different ways. And I think that I think we need to sit with what we've been taught and what we've learned over this past even decade to think about how do we leverage that to move us forward, right? So because the things we need to change are just that big, they're just that large, and so I think that we have to be thinking about how do we build power? What does that look like? And how do we lean into the insights of social movements to do that work?
Yeah, I think that's an excellent segue to talking about the collaborative that we're trying to form. So we're forming this collaborative. The idea was that health equity, as someone pointed out previously in the conversation, health equity, we've kind of beaten people over the head with it, and it's kind of a thing that people, at least if nothing else, they know it's a thing, right? They may not agree that it even exists, but they know there's this thing out there called health equity, and we're putting a lot of resources into it. And people from many different sectors have been doing stuff, right? So, and I almost said crap, Sinsi, but they doing stuff, right? So you've got people in the private sector doing stuff, people in the public sector, community organizations, communities, universities, researchers, all of that. And everyone's off doing their own thing and being driven by their own set of incentives, I guess, that's motivating their action. How do we create more synergy across these sectors? How do we get people to come together and work in a more coordinated fashion? Presumably that coordination would lead to more progress. Any thoughts about that?
I think a couple of things. So one, and this is something that we've spent some time at Grantmakers in Health, there are, to use a radar analogy, a lot of dots coming up on the radar that we're trying to connect in terms of exactly what you're just saying. I think one of the things is a little bit of an ask that I would say for those who may be entering the space a little bit newer is to just stop and sort of ask yourself who's in the space, even in your local area, who's been doing this, and try and sort of reach out. I talked a little bit about this a couple of years ago as sort of entering the space with cultural humility and understanding what's already been there, what the landscape looks like. I think the other piece that we need is kind of a common roadmap. And so what is the roadmap to move us forward in this space? If there are 3 to 5 things that we could all work on that would help to move progress and working at different levels to help us move forward. So I think what that roadmap looks like that can get us going there so that we're all swimming in the same direction, if you will. And then lastly, I think that, we do need to think big and think about the structural changes that we need to be making and to have pushing on those at what we need to have from a policy standpoint to bake this in so it is sustainable as we move forward. And the last thing I would say is we need to have a lot more conversation, attention, and focus on the pathways that we are not focused on to create the future workforce and communities that we need. We have seen, people have hired however many diversity officers, equity officers, want to diversify their boards. There just aren't enough bodies across all of the populations if we aren't focusing on increasing college graduation rates for communities of color and thinking about how we're developing our healthcare, education, government, law, business, science, tech, whatever workforce, so that it looks like our communities. And that is not work that's going to be happening overnight again, but we need to have a lot more conversation about pathways and how we're creating more pathways for people to get through to be they're living their fullest potential, which obviously has economic income outcomes and reduces disparities.
Yeah, I want to double down on what Kara's saying about the need for kind of like a roadmap, because we're past the time when we think about, we need people to stop thinking about like these inequities like the weather, like something that just happens, right? Although we also know that the weather doesn't just happen, that we actually influence the weather, but these are decisions, right? Decisions that have been made. And so part of the roadmap, I think, needs to be giving people, not just people who think of themselves as equity experts, but everyone, kind of tools to help disrupt the status, the standard operating procedure, and asking the right questions. Like, who is not at this table? How is, and we at the partnership recently put together like a tool that actually looks at both in terms of research development and policy development and implementation at different stages. What are questions to ask? To stop for a minute, pause and say, like, am I asking the right question here, or am I asking the wrong question? And so much of it has to do with surfacing issues, and especially with going to the people who are the actual experts, who are the people with a lived experience, right? And so having a roadmap that is not so much about like, this is what you do in healthcare, this is what you do in education, but these are the right questions to ask, to interrogate the structures underneath, and to design changes to the structures. Those are the kind of things that I think will be really useful, even, and you don't have to become a DEI expert to be able to use it, right? Because that's the other thing. As Cara says, there are just not enough of us to go around right now. So those are kind of my initial thoughts on how we could work together in one direction.
It seems to me that the gatekeepers of who gets to be a part of these different sectors and disciplines is critical here. So, and typically that's universities. That's who trains people to be lawyers or physicians or public health researchers or nurses and so forth and so on. What's the role of universities, and how do we change universities to produce people that are thinking more along the lines of what we're talking about in this conversation?
I think academic institutions have to start early. This whole idea of pipelines, I'm a bit, a little kind of annoyed with that term in some ways, because I remember years ago growing up, Black in North Carolina, and there was this one day when we would have this critical mass of African-American leaders and to fill all these positions. And I've still been waiting on that day to happen. And it just hasn't. And it's unfortunate. And I think so the role of academic institutions, for me, community campus partnerships for health, is really to forge real partnerships with the community around educating young people, starting even at K-12, K through 12 work. That's what I'm looking for academic institutions to do, is to me, if you wait until the freshman year, it's almost too late, quite frankly. I think it has to be very much upstream. It requires kind of tearing down the walls and working in communities like Tulane, really immersing itself in New Orleans and every academic institutions. And I want to bring attention to even the role of historically Black colleges and universities, the important role that they must have in other minority serving institutions to start early. So I've been sitting here thinking about this nationalized approach. And I think that there has to be an academic approach to some of these issues, but it really requires them to think a lot about how they intersect with their own local communities and supporting the education and the development of the bright, smart minds around them every day. The children of the people that work in the basement, the children of the people that are nurses, assistants at healthcare systems, all of that, like what, if they could think about that and approach it from that perspective, I think that would actually serve to garner a lot of goodwill in the community and address some of the more systemic issues that we see. In fact, the communities where we have some of the largest universities in the world, in the US, are some of the poorest, most resource limited communities. And that really should not be.
I completely agree with Al. Academic universities are part of the community. They pull the workforce from the community, and it's not just the professors, but the people who are working in the dining halls and all of those places. And it is, it behooves them as well as others. And I think it is, again, changing our mindset. And I can't remember, Thomas, if it was you or Al, who sort of talked about our immediate kind of gratification and sort of thinking about ourselves and what's best for us. But we need a less centered approach and a more holistic approach to this, because it does serve all of us getting earlier into community, developing those relationships, helping kids to see that there is a pathway for them to go to whatever it is that they want to do to fulfill their dreams, and providing some of those resources and those needs. I think that we talk about, income inequality in this country. And, I heard today something about, we're going to do this for those who are 600% over the federal poverty level. Most people, other than those on this call, maybe have no idea what the federal poverty level is. And we need to talk about it in language that resonates with people, to say that if you are an individual who's living on $13,000 or $14,000, you're not considered poor in this country. But you can't, that's not college. You're not going to college, given the cost of college today, or any, community college or whatever the training may be afterwards. So thinking about how we do that the same way that we're putting in together, the focus in hospitals with their community health assessment, community needs assessments, and pushing them into community. All of our big institutions, health systems, hospitals, academic universities and colleges are part of the community and need to be thinking about how they're working with community to support it, because it benefits everybody.
Okay, and on that note, I see we're running low on time, and I wanted to thank you for this fascinating conversation. We touched on many topics and many issues that are precisely the reason that we've created this learning collaborative. And hopefully, as we continue to have these conversations, we'll be able to put some meat on the bones and get down to the brass tacks of how we actually enact some of these policies. So thank you for sharing your thoughts and wisdom on these topics. And we hope that you found this time productive and that you'll join us as we continue our collaborative learning through a calendar of activities following this webinar. The first of which will be an interactive discussion which is taking place on April 12th. Please become a part of the process. Visit our website for information on P4HE and upcoming events, how to become a member, and follow us on social media. We'd love to hear how you think about health equity, and please take a minute to answer the survey that you'll find in the chat. Thank you for joining us. Looking forward to continuing the conversation in our next virtual interactive event on April 12th.